For months, I kept finding the same pattern across the research. Different populations, different institutions, different methodologies, but all of them pointing to the same unexpected conclusion: the fatigue, the mental fog, the unexplained weight gain that so many women experience after 50 isn't simply about hormone loss. The research kept pointing somewhere deeper, somewhere most conventional health advice never looks. I'm Linda Bellucci, a health researcher and science translator. I've spent over 15 years analyzing peer-reviewed research on aging, metabolism, and women's health, and what I'm about to share comes directly from that literature. Not theory, not anecdote, evidence. As always, what I'm sharing today is educational. If you take medication or have a diagnosed condition, please talk to your doctor before making any changes based on what you hear here. Now, what the research kept pointing to was this. By the time a woman reaches her mid-50s, she has typically lost somewhere between 30 and 50% of her functional mitochondrial capacity. 30 to 50%, not from disease, from the intersection of estrogen decline, age-related changes in mitochondrial DNA, and the accumulated burden of the modern environment. And here's what stopped me in the research. We now know, with more precision than ever before, exactly what rebuilds it. Today, I'm walking you through all 20 of those interventions. Some are backed by level A evidence, multiple randomized controlled trials in older adults confirmed by human muscle biopsy studies. Some have strong mechanistic data with emerging clinical evidence, and 2 or 3 sit genuinely at the frontier, biologically plausible, early stage, worth understanding. I'll tell you exactly which is which throughout this investigation, because the point isn't to impress you with everything that might work. The point is to give you the clearest possible picture of what the science actually says. Before we go deeper, if you're finding this investigation valuable, subscribing helps me keep bringing this level of analysis to topics like this. No pressure, I just appreciate the support. The first time I encountered serious mitochondrial data in the context of menopause, I was reading a 2024 study published in the Journal of Applied Physiology. The researchers had recruited sedentary older adults, run them through 12 weeks of structured exercise, and then done something remarkable. They took muscle biopsies and looked at mitochondria under an electron microscope, not blood markers, not questionnaires, actual images of actual mitochondria inside muscle cells. What they documented was a measurable increase in mitochondrial volume, number, and perimeter. The mitochondria had grown in size and multiplied in number in 12 weeks. That finding landed differently than most things I read because it answered a question that had been nagging at me across the prior literature. Is this decline reversible? And the answer, it turns out, is yes, but only if you understand the specific biological levers involved. A 2025 meta-regression published in Sports Medicine went further, analyzing the relationship between training type, fitness level, and mitochondrial outcomes across dozens of studies. The key finding: lower initial fitness predicted greater mitochondrial gains, which means the women who most need this information are also the ones with the most to gain from acting on it. The third study that shaped how I understand this topic was a 2023 biopsy analysis, PMID 230-90317, that followed older women through 12 months of resistance training. It documented something precise and counterintuitive. Mitochondrial volume increased from 0.86% to 1.19% of total muscle cell volume. That sounds like a small number, but what it represents is a fundamental shift in the metabolic architecture of the cell, a shift toward more efficient, larger format mitochondria. And it happened in women who were, before the intervention, essentially sedentary. Stay with me, because the protocol I'm going to walk you through draws directly from these findings. And what emerges from them is more organized and more accessible than most people expect. One more piece of evidence before we move into the mechanisms. A 2025 review in Annual Reviews of Physiology described exercise not as a lifestyle recommendation, but as what the authors called mitochondrial medicine. Their argument was that the molecular cascade triggered by physical stress, specifically the activation of a protein called AMPK, which then signals another protein called PGC1A, is the most powerful endogenous mitochondrial regeneration system the human body possesses, and it can be activated at any age, including 72, including 80. The biology doesn't expire. Once I understood what the research showed was possible, I had to understand the mechanism. What is actually happening in the body when mitochondria decline after menopause, and what reverses it? The answer involves 5 interconnected systems that the research has mapped with increasing precision, and which almost nobody discusses as a unified picture. The first is what I'd call the estrogen-mitochondrial axis. Estrogen isn't just a reproductive hormone, its receptors are expressed inside mitochondria themselves on the inner mitochondrial membrane, where it directly regulates the activity of the electron transport chain, which is the machinery that converts fuel into ATP, the energy currency your cells actually run on. When estrogen declines in the years around menopause, the electron transport chain becomes measurably less efficient. It leaks. It produces more reactive oxygen species, the cellular equivalent of exhaust fumes, and less usable energy per unit of fuel consumed. This is why fatigue after menopause isn't imaginary and isn't simply about sleep. It has a molecular address. That's the first piece. The second is the NAD plus depletion cascade. NAD plus, nicotinamide adenine dinucleotide, is a coenzyme that sits at the intersection of mitochondrial function, DNA repair, and cellular aging. Its levels decline by roughly 50% between the ages of 40 and 60. Without adequate NAD+, a family of proteins called sirtuins can't function properly, and sirtuins are the guardians of mitochondrial quality. They regulate when old or damaged mitochondria get cleared through a process called mitophagy, and when new ones get built through biogenesis. Drop NAD+ levels enough, and you get a double problem. Mitochondria are damaged faster and replaced more slowly. But this system doesn't work alone. Enter the third process, which I describe as the AMPK-PGC1A signaling cascade. PGC1A is the master regulator of mitochondrial biogenesis, the molecular switch that tells the cell to build new mitochondria. It's activated primarily by energy stress, exercise, fasting, cold exposure, heat. When the body detects that energy demand exceeds supply, AMPK is activated, which in turn switches on PGC1A, which then coordinates the production of mitochondrial proteins, increases the expression of NRF1 and TFAM, the transcription factors that actually construct mitochondria, and over days to weeks, the mitochondrial population inside muscle cells expands. Now watch what happens when you add the fourth factor: chronic low-grade inflammation. The research consistently shows that elevated inflammatory cytokines, particularly IL-6 and TNF-alpha, both of which rise after menopause as estrogen's anti-inflammatory protective effects recede, suppress PGC1A directly. This is a critical and underappreciated link. Chronic inflammation doesn't just make you feel tired. It specifically inhibits the molecular switch that builds new mitochondria, which means reducing systemic inflammation isn't just good for joint health. It is literally a prerequisite for mitochondrial recovery. The fifth and final mechanism in this picture is the cortisol PGC1A suppression axis. Psychological stress research, particularly the work of Picard and colleagues at Columbia University, has documented something remarkable. Perceived psychological stress is measurably correlated with altered mitochondrial morphology in white blood cells. Mitochondria are stress sensors. Chronic cortisol elevation suppresses PGC1A through a documented molecular pathway, which means the stress reduction advice in this field isn't soft or vague. It has a specific biological mechanism, and that mechanism has been verified in humans. These 5 systems, estrogen withdrawal, NAD plus depletion, blunted AMPK PGC1A signaling, inflammation-driven suppression, and cortisol-mediated inhibition, are the landscape into which all 20 interventions operate. Understanding them changes how you read everything that follows. Each of the 20 interventions targets one or more of these pathways, with varying degrees of evidence behind each. The next piece explained a pattern I'd been puzzling over for years. Why the same set of interventions that help with energy also seem to reduce cognitive fog, reduce joint inflammation, and improve sleep quality simultaneously. The answer is that mitochondria are the central hub of all of these. When the hub is compromised, everything downstream suffers together. When you restore the hub, multiple systems recover at once. Let me walk you through the 20 interventions in 5 categories, and I'll be explicit about evidence levels throughout. The exercise category carries the strongest evidence of all, level A, meaning multiple randomized controlled trials confirmed in humans. The most powerful single tool in the mitochondrial recovery toolkit is high-intensity interval training, not because it's trendy, but because of what the biopsy studies confirm. HIIT is the most potent AMPK activator available to us. A short burst at 80 to 90% of maximum heart rate creates the exact metabolic stress that triggers the entire PGC1A cascade. The Journal of Applied Physiology study I mentioned earlier confirmed this through electron microscopy. Not just improved energy levels, but physically measurable increases in mitochondrial count and volume. The protocol the evidence supports: 3 sessions per week, 5 to 8 rounds of 30 to 60 seconds at high intensity, with recovery intervals. Total time 20 to 25 minutes, including warm up. For beginners, walking intervals work: 30 seconds fast, 90 seconds normal pace. And here's a finding I find consistently underappreciated in the literature. Mitochondrial improvements from HIIT are detectable within 6 sessions, 2 weeks if you're training 3 times a week. This isn't a 6-month project to see a signal. The biology responds quickly. Resistance training occupies a different but complementary position. Each gram of muscle tissue contains thousands of mitochondria. Resistance training increases muscle cross-sectional area, which means it expands the total body mitochondrial pool even independent of changes in mitochondrial density. The 12-month biopsy study in older women confirmed this: measurable increases in mitochondrial volume and a shift toward larger, more efficient mitochondrial formats. The protocol: 2 sessions per week, 8 to 10 compound exercises, 2 to 3 sets of 8 to 12 repetitions, with progressive overload over time. HIIT and resistance training are synergistic. They activate complementary pathways and together produce results neither achieves alone. Zone 2 cardio is the third exercise lever, and it serves a different purpose than the first two. Zone 2, roughly 60 to 70% of maximum heart rate, a pace where you can hold a conversation, is the zone where mitochondria preferentially burn fat as fuel. Sustained training at this intensity doesn't just improve cardiovascular fitness. It specifically trains mitochondria to become more metabolically flexible, more proficient at fat oxidation. The sports medicine meta-analysis from 2025 documented consistent mitochondrial content increases from steady endurance training, with greater gains in people with lower initial fitness. Think of Zone 2 as building a larger metabolic engine. HIIT then optimizes that engine for power output: 30 to 45 minutes, 2 to 3 times per week. Brisk walking, cycling, swimming, or dancing all qualify. The fourth exercise lever is post-meal walking, and it's probably the highest return on effort intervention in this entire list. 10 to 15 minutes of walking after meals activates AMPK in muscle cells, allowing those cells to take up glucose from the bloodstream independently of insulin. Multiple small randomized controlled trials show this blunts the post-meal glucose spike by 30 to 50% compared to sitting. That glucose management matters for mitochondria in a specific way. Elevated post-meal glucose produces a surge of reactive oxygen species in the mitochondrial electron transport chain, exactly the kind of chronic mitochondrial stress that accelerates decline. Post-meal walks interrupt that cycle at essentially zero cost. The second category is nutrition timing, and here the evidence is level B, well supported by multiple human trials. Time-restricted eating has emerged as one of the most mechanistically rich nutrition interventions in the aging literature. The idea is simple: extend the overnight fast to somewhere between 12 and 16 hours. Stop eating at 8 p.m., have breakfast at 8 a.m., that's a 12-hour fast. Extend dinner to 7 p.m. and delay breakfast to 9 a.m., and you're at 14 hours. What happens biologically during this window? AMPK is activated during the fasting state. SIRT1, one of the NAD plus dependent sirtuins that governs mitochondrial quality, becomes more active. Autophagy and mitophagy, the cellular cleanup processes that clear damaged mitochondria, accelerate. Insulin exposure drops, which reduces IGF-1 signaling, which in turn reduces the oxidative stress burden on the mitochondria. Multiple randomized controlled trials in overweight and obese adults show reduced fasting insulin, reduced C-reactive protein, reduced blood pressure, and reduced body fat from 12 to 16-hour TRE. For women 50 and older, the sweet spot based on the evidence is 12 to 14 hours. Longer fasts, beyond 16 to 18 hours, introduce muscle catabolism risk that outweighs the benefit in this population. Protein distribution is the second nutrition timing intervention, and it's subtle but important. Muscle protein synthesis, the process of building and maintaining muscle, which is the primary mitochondrial reservoir, is most efficiently stimulated by doses of 25 to 35 grams of protein per meal in older women. This is higher than the threshold needed in younger adults because the leucine sensitivity that triggers protein synthesis is blunted with age. Distributing protein across 3 meals rather than consuming most of it at dinner, which is the common pattern, produces measurably better muscle maintenance in the studies. 25 to 35 grams at each of 3 meals, prioritizing leucine-rich sources: eggs, Greek yogurt, fish, legumes. The third nutrition timing intervention is circadian nutrition, eating the majority of calories in the first half of the day. Insulin sensitivity follows a clear circadian rhythm in humans. It's highest in the morning and lowest in the evening. Consuming the same foods earlier in the day produces significantly lower insulin and glucose responses than consuming them later. Multiple chronobiology trials show that early time-restricted eating, where breakfast and lunch are the substantial meals and dinner is light, produces greater improvements in metabolic markers than later eating patterns with identical food content. The practical protocol: 60 to 70% of daily calories before 3 p.m., a light dinner, and no eating after 7 or 8 p.m. The third category is targeted nutrition, specific compounds with level B evidence for mitochondrial support. Magnesium is where I'd start, and here's why. ATP is only biologically active when bound to magnesium. Your mitochondria can produce ATP, but if magnesium is insufficient, that ATP cannot be used efficiently. It's like printing money that can't circulate. And Haines survey data shows that more than half of U.S. adults over 50 consume below the estimated average requirement for magnesium. The deficiency is widespread and largely invisible. It doesn't announce itself with a dramatic symptom, but shows up as chronic fatigue, muscle weakness, and impaired cognitive function. 300 to 400 milligrams of elemental magnesium per day in the glycinate form for best tolerance, taken in the evening. Magnesium glycinate also supports sleep onset and has been shown in some studies to reduce hot flash intensity, which matters for mitochondria because hot flash disrupted sleep impairs mitophagy, as I'll describe shortly. CoQ10, specifically in the ubiquinol form, is the next targeted compound. CoQ10 is an electron carrier inside the mitochondrial electron transport chain. It physically shuttles electrons between complexes. After 40, endogenous production declines. Statin medications deplete it further by blocking the same biosynthetic pathway. The ubiquinol form, the reduced active form, is significantly better absorbed in older adults than the more commonly sold ubiquinone form. 100 to 200 milligrams per day with a fat-containing meal. If you're on a statin, this isn't optional. It's correcting a drug-induced depletion of a molecule your mitochondria depend on. Alpha lipoic acid occupies a unique biochemical position because it's both water and fat soluble, allowing it to work as an antioxidant in both aqueous and lipid environments inside and around the mitochondria. More specifically, it's a cofactor in two key mitochondrial enzyme complexes, the pyruvate dehydrogenase complex and alpha ketoglutarate dehydrogenase, that sit at critical junctions in energy metabolism. At 600 milligrams per day, oral ALA has demonstrated efficacy for insulin resistance and diabetic neuropathy in multiple trials. The R-ALA form is more bioavailable than the racemic mixture. Two important interactions. It can lower blood glucose, which matters if you're on diabetes medication, and it reduces thyroid medication absorption if taken at the same time. Space them by at least 4 hours. PQQ, pyrroloquinoline quinone, is one of the few dietary compounds with evidence specifically for stimulating the number of mitochondria, not just improving existing function. It activates PGC1A and NRF2 directly. A small Japanese human study showed cognitive and metabolic improvements at 20 milligrams per day over 8 weeks. The evidence is emerging rather than definitive, but the mechanistic data is strong and the human signals are consistent. PQQ is often combined with CoQ10 in supplements, and the combination has more human data than PQQ alone, 10 to 20 milligrams per day. NAD plus precursors, either NMN nicotinamide mononucleotide or NR nicotinamide riboside, address the NAD plus depletion I described in the mechanisms section. Multiple human randomized controlled trials from 2020 to 2024 confirm that both NR at 300 milligrams per day and NMN at 250 to 500 milligrams per day effectively raise blood NAD plus levels in older adults. Some cohorts showed improvements in metabolic markers. The full clinical efficacy picture in postmenopausal women specifically is still emerging. Large trials are ongoing, but the biochemical rationale is strong. The safety profile to date is favorable, and the synergy with exercise is real. Exercise and NAD plus precursors both activate SIRT1, and their effects compound. The fourth category is thermal and environmental stressors, using deliberate exposure to heat or cold as hormetic triggers. Evidence here is level B for the primary interventions. Sauna therapy activates heat shock proteins which protect and repair mitochondrial proteins. Think of them as a repair crew that gets called in when the cell is under thermal stress. Sauna also activates PGC1A through heat stress AMPK signaling, producing some of the same mitochondrial biogenesis signals as exercise. The large Finnish population studies, Laukkanen and colleagues published in JAMA Internal Medicine and related journals, documented that 4 to 7 sauna sessions per week were associated with dramatically reduced cardiovascular mortality over long follow-up periods. Traditional dry sauna, 80 to 100 degrees Celsius, 15 to 20 minutes per session, 2 to 4 times per week. Infrared sauna operates at lower temperatures, 60 to 70 degrees, with longer sessions of 30 to 45 minutes, and may produce comparable mitochondrial signaling through different temperature receptors. Hydration is essential. Avoid sauna if you have uncontrolled blood pressure, a recent cardiovascular event, or are using alcohol beforehand. Cold exposure works through a completely different mechanism. Brief cold activates brown adipose tissue, a metabolically specialized fat that is extraordinarily dense with mitochondria because its entire function is to generate heat through a process called uncoupled respiration. Cold also triggers a surge of norepinephrine, which activates PGC1A in both brown and white fat and has documented anti-inflammatory effects. A 2025 paper in Aging Cell referenced cold-induced changes in microRNA expression that specifically increased PGC1A and TFAM, the transcription factors of mitochondrial biogenesis. The practical entry point: end your normal shower with 30 to 60 seconds of cold water. That's it. That threshold is physiologically sufficient to trigger the norepinephrine response. Escalation options include cold face immersion or cool water bathing. This isn't recommended for those with Raynaud's disease, peripheral artery disease, or uncontrolled hypertension. Vitamin D completes the environmental category. Vitamin D receptors are expressed inside mitochondria, where vitamin D activates mitochondrial transcription factors. Deficiency, which is extremely common in women over 50, particularly those living at northern latitudes or spending limited time outdoors, is associated with increased fatigue, muscle weakness, and reduced mitochondrial enzyme activity in the studies. The target, serum 25-hydroxyvitamin D between 40 and 60 nanograms per milliliter, 15 to 30 minutes of morning sun exposure on arms and legs 3 to 5 times per week, or supplementation with 1,000 to 2,000 IU of D3 daily, adjusted based on serum testing. The fifth category is mind, body, and recovery. And while this category has the softest evidence for mitochondria-specific mechanisms, the evidence is real and the physiological rationale is solid. Sleep is the highest priority recovery intervention. Mitophagy, the clearance of damaged mitochondria, the cellular equivalent of taking out the trash, occurs primarily during sleep, concentrated in deep, slow-wave sleep stages. Sleep deprivation studies show measurable increases in 8-OHDG the following day, a biomarker of oxidative DNA damage that reflects mitochondrial reactive oxygen species production. In postmenopausal women, hot flash-disrupted sleep creates a specific problem. Fragmented sleep reduces mitophagy efficiency, meaning damaged mitochondria accumulate faster. The protocol: 7 to 9 hours with a cool bedroom between 65 and 68 degrees Fahrenheit, and magnesium glycinate at 300 milligrams at bedtime, which, as I mentioned, also supports sleep onset directly. For women with severe hot flash disruption, this is a conversation worth having with a physician, as there are multiple evidence-based management options. Chronic stress reduction addresses the cortisol PGC1A suppression axis I described in the mechanisms section. This isn't about attitude or optimism. It's about measurably reducing cortisol, a documented molecular suppressor of mitochondrial biogenesis. Yoga in postmenopausal women has been evaluated in multiple small randomized controlled trials and shows consistent reductions in cortisol, C-reactive protein, and improvements in quality of life. 10 to 20 minutes of daily mindfulness, breathwork, or yoga represents a minimum effective dose. The evidence supports any consistent practice that reduces sympathetic nervous system activation and lowers cortisol chronically. Melatonin is not just a sleep aid. It has direct mitochondrial effects that are increasingly well documented. Melatonin acts as an antioxidant specifically inside mitochondria, scavenging reactive oxygen species at the electron transport chain itself. It activates mitophagy through the AMPK PGC1A pathway, and melatonin production declines sharply after 50, which means its mitochondrial protective role is being withdrawn at the same time that mitochondrial stress is increasing. The protocol: 0.3 to 1 milligram, 30 to 60 minutes before bed. This is dramatically lower than the doses found in most commercial products, and the evidence supports lower doses for older adults. Higher doses can cause next-day sedation without additional benefit. Important interactions: melatonin may interact with anticoagulants and immunosuppressants. Intermittent protein restriction represents a more advanced intervention with a strong mechanistic basis and emerging human data. When dietary protein is restricted, specifically when amino acids are absent, mTOR, the cellular growth signal, is suppressed. mTOR suppression activates autophagy and mitophagy more powerfully than calorie restriction alone. Valter Longo's group has documented this mechanism through fasting mimicking diet studies showing cellular renewal markers in humans. A practical implementation: 1 plant-only day per week or a monthly 5-day plant-based low-protein cycle as studied by Longo's team. The evidence is level B for general autophagy activation, level C for mitochondria-specific effects in this population specifically, not appropriate for anyone with sarcopenia, low body mass index, or a history of disordered eating without physician guidance. Red light therapy closes the 20 interventions, and I want to be transparent about where the evidence stands. Near-infrared and red light in the 630 to 850 nanometer range is absorbed by cytochrome C oxidase, complex IV of the mitochondrial electron transport chain. This is a real photochemical interaction, not speculation. The proposed effects are increased electron transport chain efficiency, reduced reactive oxygen species, and stimulated biogenesis. Multiple small randomized controlled trials show real benefits for wound healing, muscle recovery, and cognitive function in older adults. A 2023 preliminary study showed improved energy and reduced fatigue in postmenopausal women. But this is genuinely early stage evidence, level C. It is one of the most scientifically plausible frontiers in mitochondrial research, and the mechanistic rationale is strong. But it should be understood as promising and preliminary, not established. Devices range from $100 to over $1,000, and none of this is reimbursed by insurance. If budget and interest align, it's worth watching the emerging evidence. If not, the first 19 interventions are far more established. Let me walk you through how to actually implement this. The research supports thinking in 4 tiers, organized not by complexity, but by evidence strength and practical foundation. Tier 1 is where the evidence is strongest and the return is highest. HIIT 3 times per week, resistance training twice per week, sleep optimization, 7 to 9 hours, cool room, magnesium glycinate at bedtime, magnesium 300 to 400 milligrams daily, and post-meal walks, 10 to 15 minutes after each meal. These 5 interventions are accessible, low cost, and backed by the most robust evidence in the entire list. They also compound. Better sleep improves exercise recovery, which improves mitochondrial response to training, which improves metabolic flexibility, which improves sleep. In month 2, add Zone 2 cardio 2 to 3 times per week. Extend to a 12 to 14-hour overnight fast. Distribute protein to 25 to 35 grams per meal across 3 meals. Begin a 10-minute daily stress reduction practice, yoga, breathwork, or meditation. If you're on a statin, add CoQ10 ubiquinol at this stage. If you're not, it's optional but supported. In months 3 through 6, layer in alpha-lipoic acid at 300 to 600 milligrams daily, NAD plus precursors at the doses I described. Circadian front-loading of calories, sauna 2 to 4 times per week if it's accessible, and vitamin D optimization with serum testing if you haven't already done it. From month 6 onward, consider cold shower finishes, low-dose melatonin if sleep remains disrupted, PQQ combined with CoQ10, the intermittent protein restriction protocol if medically appropriate, and red light therapy if budget allows and interest is high. The timeline the studies support, weeks 1 through 6, the mitochondrial response to HIIT is detectable within 6 sessions. Sleep and magnesium improvements are often felt within 2 weeks. By months 2 to 4, metabolic markers, fasting insulin, C-reactive protein begin to shift in people who've layered in Tier 2. By months 4 through 12, the Tier 3 and 4 additions build on a foundation that is already functionally different. You're not adding supplements to a broken system at that point. You're optimizing a system that exercise, sleep, and nutrition timing have already begun to repair. One safety note before I close. HIIT requires medical clearance if you have known cardiovascular disease, recent cardiac events, or uncontrolled blood pressure. Alpha-lipoic acid interacts with thyroid medication and diabetes drugs. CoQ10 interacts with warfarin. Melatonin interacts with anticoagulants and immunosuppressants. Time-restricted eating is contraindicated in people with a history of eating disorders, type 1 diabetes, or certain medications. The intermittent protein restriction protocol is not appropriate without physician oversight for anyone with sarcopenia or low body weight. Cold exposure has contraindications including Raynaud's disease and peripheral artery disease. Seek immediate medical attention for any chest pain, shortness of breath, or fainting during exercise, or sudden severe fatigue that is categorically different from the gradual kind this video addresses. We started with a question about pattern. Why does the research point so consistently toward mitochondrial decline as the unifying mechanism behind so much of what women experience after 50? The answer, it turns out, is that mitochondria are not peripheral to human health. They are central. They sit at the intersection of energy, inflammation, hormonal signaling, and cellular repair. When they decline, everything they support declines with them. When they recover, the downstream effects are broad and real. The 20 interventions I've walked through aren't a wish list. They're a catalog of documented biological levers, organized by evidence strength, sequenced for practical implementation. Some of them, HIIT, resistance training, sleep, magnesium, you can begin this week. Others require building a foundation first, or medical consultation. All of them have a mechanistic basis that the peer-reviewed literature supports with varying degrees of certainty. What I find consistently remarkable in this research is not the complexity of the biology, though it is genuinely complex, but the fact that so much of what the evidence supports is accessible. Walking after meals, 7 to 9 hours of sleep, 20 minutes of interval training 3 times per week. These are not exotic. They are structurally simple interventions that happen to have profound cellular effects because they activate the same molecular pathways, AMPK, PGC1A, SIRT1, NRF2, that evolution built into the human cell as the core mechanisms of resilience. You have more biological control over this trajectory than the conventional health narrative typically suggests. That's not optimism, that's what the data shows. If this investigation resonated, the related video on why mitochondria decline specifically after 50, covering the estrogen-mitochondrial connection in depth, goes deeper on the mechanisms I introduced today. It's the foundational piece that makes everything in this video make more sense. Comment below with your biggest takeaway or the question this raised for you. I read every one and they genuinely guide what I investigate next. Keep investigating. I'll see you in the next one. Monica Linda Bellucci.